Welcome to Pulse&Pressors, where critical care gets crystal clear. This module focuses on escalation from pharmacologic failure to mechanical circulatory support, also known as MCS. Refractory shock is defined by any of the following conditions: mean arterial pressure, MAP, less than 65 millimeters of mercury despite using 2 or more vasopressors. Cardiac index below 2 liters per minute per square meter, even with inotropic support. Lactate greater than 4 millimoles per liter and rising despite treatment. Mixed venous oxygen saturation below 60% with elevated filling pressures. When these findings persist, it means the patient has reached the limit of pharmacologic therapy, and mechanical support becomes necessary. Cardiac power and pulsatility indices quantify the mechanical work of the heart. Cardiac power output equals the product of mean arterial pressure, MAP, and cardiac output divided by 451. CPO equals MAP multiplied by cardiac output divided by 451. Normal value, greater than 1.0 watt. Shock value, less than 0.6 watt. Critical collapse, less than 0.3 watt. CPO represents the total mechanical energy the left ventricle generates to drive blood through the systemic circulation. Cardiac power index equals the product of MAP and cardiac index divided by 451. Values below 0.4 watts per square meter indicate severe pump failure requiring mechanical support. Pulmonary artery pulsatility index evaluates right ventricular performance. PAPI equals pulmonary artery systolic pressure minus pulmonary artery diastolic pressure divided by central venous pressure. A PAPI value below 1.0 means the right ventricle cannot generate adequate pulsatility and likely requires right-sided support, such as the Impella RP or Veno-Arterial ECMO. The central venous arterial carbon dioxide gap compares venous and arterial carbon dioxide pressures. The gap formula is partial pressure of carbon dioxide in venous blood minus partial pressure of carbon dioxide in arterial blood. A gap greater than 6 millimeters of mercury indicates stagnant capillary flow or incomplete microcirculatory recruitment, even if blood pressure and oxygen saturation seem normal. This marker helps identify hemodynamic incoherence, where global numbers look adequate, but tissue perfusion remains impaired. Mechanical circulatory support, MCS devices, restore perfusion when the native heart can no longer sustain flow. Each device works through a distinct physiologic mechanism. Intra-Aortic balloon pump IABP inflates during diastole to increase coronary perfusion and deflates just before systole to reduce afterload. It is indicated for ischemic cardiogenic shock after myocardial infarction, but contraindicated in aortic root grafts, aortic dissection, or severe aortic regurgitation. The Impella system is an axial flow pump that directly unloads the ventricle. Left-sided models draw blood from the left ventricle and deliver it to the aorta. Right-sided models, such as Impella RP, transfer blood from the right atrium to the pulmonary artery. Always confirm positioning with echocardiography. Maintain activated clotting time, ACT, between 160 and 180 seconds. The Impella reduces left ventricular end diastolic pressure, LVEDP, decreases wall stress, and restores forward cardiac output, allowing myocardial recovery. Veno-Arterial extracorporeal membrane oxygenation provides full cardiopulmonary bypass support. Venous blood is drained, oxygenated, and returned to the arterial system. While ECMO restores systemic perfusion, the retrograde flow into the aorta increases left ventricular afterload and may cause distension or pulmonary edema. In such cases, left ventricular venting, or a hybrid configuration known as ECPELLA, may be required. ECPELLA configuration combines VA-ECMO with an Impella device to provide simultaneous oxygenation and ventricular unloading. This setup is especially beneficial for patients who develop Harlequin syndrome, also called differential upper body desaturation, where oxygenated and deoxygenated blood mix due to partial native cardiac ejection. It is also used when ECMO alone causes excessive left ventricular distension. After mechanical support is initiated, optimization focuses on restoring both macro and microcirculatory balance. The goals are mean arterial pressure, 70 to 80 millimeters of mercury. Cardiac index, greater than 2.2 liters per minute per square meter. Mixed venous oxygen saturation, 65 to 75%. Central venous arterial carbon dioxide gap, less than 6 millimeters of mercury. Lactate, downward trend with clearance of at least 10% per hour. Urine output, greater than 0.5 milliliters per kilogram per hour. Central venous pressure, 8 to 12 millimeters of mercury. Pulmonary capillary wedge pressure, 12 to 16 millimeters of mercury. During VA-ECMO support, rising wedge pressure or pulmonary edema indicates inadequate left ventricular unloading. Consider Impella or venting. For right-sided support, clinical improvement is seen when CVP decreases and PAPI rises toward normal. Weaning begins when the following recovery parameters are achieved. Cardiac power output, greater than 1 watt. Cardiac power index, greater than 0.5 watts per square meter. Mixed venous saturation, stable within 65 to 75%. Lactate, normalized or consistently declining. Mechanical circulatory support is not a failure of medicine. It is the continuation of physiology through engineering. It preserves oxygen delivery and systemic perfusion while the heart and microcirculation recover. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.